Hey, welcome back, everybody, to the We Fix Pain podcast. This is episode number 24 with Dr. Brandon Steele. Doc, welcome to the podcast.
Thanks for having me.
Yeah, it's been a long time. For those that don't know, Dr. Steele and I, we went to chiropractic school. He sat in front of me, or I sat behind him for 3.5, almost 4 years. So bad jokes, talking about the Cardinals on a Monday, all that stuff was stuff that, conversations that we had for years and years.
Yeah, it was actually, we were, 3 feet away from each other. The Cardinals are much worse, and I have a lot less hair if you looked at the back of me, but otherwise, pretty much the same.
Yeah. Well, family and kids will do that to you, and same to me as well.
Yeah.
Today's topic for conversation with the podcast is clinical excellence. And we're defining clinical excellence today with combining evidence-informed practice with effective patient communication. You see, I made mistakes, and I'm right off the bat, I'm throwing myself underneath the bus with all that dirty luggage. And that is, I focused way too much early in my career on building my skill set, building my knowledge base. What does the evidence say? And I forgot your outcomes are not just predicated on that. So we have a Jedi Master, fully certified Jedi Master, Dr. Steele, that's going to help us out to that tune. But first, let me introduce the podcast, what we do, why we do it. This podcast focuses on health and wellness related topics with a specific focus on neuromuscular care. We discuss injuries to muscles, tendons, ligaments, fascia, joints, and more that lead to pain. We address topics like assessment, diagnosis, treatment, rehabilitation, and management of acute and chronic related pain conditions. We thank you for listening to this podcast, and we humbly ask, if you like this material, please subscribe and share. Let me introduce Dr. Steele today. Dr. Steele is a diplomate and fellow of the Academy of Chiropractic Orthopedists. He graduated from Logan College in December 2009, just like myself. He's got bachelor's degrees from Logan University and from St. Louis University. He has produced research. That research, which he was accumulating while we were at Logan, is the effect of neuromuscular manual therapy versus myofascial release therapy on temporal joint pain and range of motion, which was submitted for publication in 2010. He's a president or past president, Doc?
Past now. So I just got off the board. It was such a high-paying, job on the board of your state association. But after 12 years of being in the state association, my tenure is done.
Yeah, more free time, right? He's past president of the Illinois Chiropractic Society, Southern District. He's got multiple postgraduate certification and training courses, and there's a laundry list here. But let's just say he's well qualified to give us the expert evidence. And he's currently in private practice at Premier Rehab. I'm going to kill it. Swansea?
Close. Swansea,
just east of St. Louis, Missouri. He's also the co-founder of Up, and Up is an integrated platform that helps provide the evidence, helps track your patient outcomes and your patient data, and helps connect the dots between what you do in the office and what a patient takes home, not just their exercises, but what's going on between the ears with patients. So that's why he's our expert here. So Doc, what's your superhero origin story? How'd you end up as a chiropractor, and how'd you end up getting into integrated neuromuscular care?
I really don't have a very good story, to be honest with you. So my background at SLU was research, biochemistry, and molecular biology. I was starting my PhD, and I was doing research every day of the week, which is 7 days a week, because your research studies have to go on through the weekends. And I loved research. I just didn't like doing research. So I realized that maybe that wasn't a good option for me. I did a pre-dental program, and I applied to get in dental school. I did not get in my first year, so I was kind of looking for other options. And my father-in-law's best friend is a chiropractor. I see him at Lake of the Ozarks on his boat, and we just talked for about an hour. He enjoyed what he did. I went and saw him for a visit. The thing that struck me as interesting is that everyone who he saw liked coming in to see him, and nearly everyone he saw felt better when they left. So it was a very fulfilling profession that I saw. And getting into it, there were some challenges, but looking back, I don't think there's a better choice for me.
Cool. Yeah, you know what? I did not know that whole story. I know that somewhere you intersected with a chiropractor, and that kind of altered the course, but I didn't know that, dental school, and then you actually which makes sense. You were always very involved in reading research when we were there, and heavily impacted you, and still to this day. So, Doc, let me get into 3 fun random questions. I know you, and we kind of joke around when we see each other at conferences and convention, but 3 kind of fun things that the patients, well, people would want to know. So, what superpower would you most want to have, and why?
Ooh, a superpower. Superpower, I'd like to manipulate time. I ask one question to my patients of a unique generation. You can figure that out after I get done with it. And I'll always ask them, hey, Sally, if you could go back to any time in your life, any year of your life, what age would you go back to, if any, and why? But I'm at a caveat and said you can't change anything. So you just have to go back and relive life from that point forward. You can't make things better. You can make different decisions. You just need to start life at that point and then just relive what you already lived. And it's so interesting because nearly every patient will say, I want to go back to when my kids are young. I want to go back to elementary school and when they're in sports and the craziness of starting a family. And it's so funny because obviously Dino and myself, we're in that stage right now, and I can't wait to get out. I'm so busy and everything's so crazy. And so if I can manipulate time and find a way to enjoy more these periods of my life and to somehow manage the time, whether professional and personal, I think that'd be pretty cool. So that'd be my superpower.
Cool. Yeah, I never would have considered that, like the end game for some is go back to the period where everybody was in a close-knit setting. And as crazy as it is, sometimes we can't see the forest through the end of the trees. And yeah, I'm in that mindset too, where some days I'm like, man, our schedule is loaded. So we're going to miss those days. All right, Doc. So what's you spent quite a bit of time in St. Louis, if memory serves me correct, right? What's your
Yes.
What's
Yeah.
your authentic, perfect St. Louis day? If you had a 1-day itinerary and you had to take somebody around town for 1 day, what's your perfect St. Louis day?
I've got 3 children. All play year-round soccer. We are, in fact, it's when are you gonna? It's May now. I don't think I've been home for a weekend since the second weekend of February. So I travel a lot, and whether it's for kids' sports or for work, I'm gone a lot. So perfect day would be first off in St. Louis, not somewhere else. It would be me making it to all 3 kids' games. Everyone scores a goal. They all play soccer. And then maybe going to a St. Louis City game afterward, having a nice dinner, and calling it a night early and getting some good sleep. I know it sounds boring, but I think my perfect day is just being in St. Louis.
Gotcha. Yeah, people sleep on St. Louis for like a weekend travel destination. There's quite a bit of things to do in St. Louis, and then the surrounding area is underrated beautiful. With you start to get to the wineries of Augusta and the rolling hills and the trees that change in the fall. It's underrated beautiful. All right, your say what moment in healthcare where a patient says something and you say to yourself, what did you just say? Can you say that again?
You know what? I don't think I have a proper answer to that one. However, I have come to one conclusion, and I've had this happen multiple times. And when I say this, I think it'll probably resonate. I've had patients who say, you know what? I got up this morning and I was wondering if I should take a shower. And I thought to myself, if you ever have to question, should I take a shower or not? The answer is always yes. It's just, it's one of those things that, patients are coming, oh, I even showered for you today. I'm like, well, geez, aren't you showering every day? So that's one thing that I'll hear that always I laugh a little bit about.
My say what moment is when I had a patient say that their scrotum was a problem. And I was like, is it low back referring into the scrotum? Because that's a big problem. And then a couple minutes in the conversation later, it's brought up again and again. And I eventually ask him to point to his scrotum, and he points to his sacrum. So, yeah. So that was like, say what? Yeah.
Yeah.
So, anyways, he's one of those people that was never wrong. So I never really corrected him and told him it was his sacrum, because I wouldn't win that conversation. Even if I showed an anatomy book, nope, that's not it. So, yeah. So, Doc, we're bringing you on because of the topic of clinical excellence and, again, integrating information into a hybrid strategy with effective communication to produce outcomes. Do we have to pick one? Do we have to give up being technically great at something to be an effective communicator, or give up effective communication to be a great adjuster, soft tissue treatment guy, rehab person? Do we have to pick one?
I think so at the beginning. And I started off, I think, being very clinically oriented, maybe similar to yourself, that I really wanted to master that skill first. And to do that, it takes a lot. I mean, it takes a lot to attend all those seminars and to integrate. Should I be doing directional therapy evaluation? Should I be using an instrument to create a controlled inflammatory reaction? Should I be considering dry needling? You have to be really good to be clinically sound. And then also we have to be a good communicator to take, really everything that we know about a condition and give it to the patient. It's kind of like, it's very similar to owning your own practice, is that just because you're a good chiropractor doesn't mean you're going to be a good business owner of a chiropractic clinic. And in the same token, just because you're a really good soft tissue person, manipulator, doesn't mean you're going to be a great doctor. And that communication skill is very difficult because we'll have a patient who is 10 years old with a shin splints, and then we'll have a 90-year-old with BPPV, and then a 55-year-old who is a PhD that has tennis elbow. Well, not only do we have to explain those conditions to our patients, but we have to explain to patients with different education levels and different understandings and different motivations. So I think that, yes, we need to be a great clinician clinically. There's no question. Each patient really should understand their condition just as well as you do, which is tough. And I am in a different system than you are, but I've got 8 minutes. I've got 15 minutes. I have to take everything that I know about a condition and somehow give that to the patient so we can work together to solve that problem. Well, that explanation has to be done coinciding with what I'm doing. I need to be treating the patient at that time, because I also, unfortunately, I get paid to evaluate and manipulate and do soft tissue. So there's an intricate balance there, and there's a skill set there of being able to integrate both communication and clinical skills at the same time. So many times I'll see providers who will kind of have their flow. I do manipulation, manual therapy, and exercise. And when you look at the research, there's nothing better. Manipulation is the tip top of the pyramid as far as the safest non-surgical, non-pharmacological care we can do for musculoskeletal care. But we also see in the research that manipulation plus manual therapy gets even better results. Manipulation plus manual therapy plus exercise gives possibly the best results. So many people get hung up on that, and they say, well, I'm just going to do the same thing for every patient. Well, we know that doesn't work. We should be, kind of tailoring our treatment to the condition, but we should also be of understanding that we can't be great at everything. So if you're the best manipulator in the world, great, keep on doing that. Find another chiropractor in your area or someone else in your area that can possibly do manual therapy and exercise for those patients who aren't getting better through manipulation. So I think that's the biggest piece, is just knowing what you're great at and continuing to get better each day, whether it's clinically or whether it's patient education. I think both need to go hand in hand. They should not be mutually exclusive. However, it takes time. Finally, I've had multiple associates in my life. I've got a tremendous one right now. However, I think he'll tell you, and I will tell you, that at the very beginning, the only thing lacking was not his communication skills. He was a very good at that, a very likable person. His clinical skills were very, very good, but confidence. And that's the one thing that I think is an overarching layer, is that regardless if it's you getting your hands on someone or you talking to someone, be confident in what you're doing. And if you're not confident in what you're doing and what you're saying, first off, don't say it or do it, and then go back and research it and make sure that what you think or what you want to do or what you want to tell a patient is factual. And it's okay not to know all the answers, and just to make sure the answers you do give are the right answers.
Yeah, there's an inherent feedback loop that has to happen, and whether we admit it or not, it's happening, where every patient is a data point, and that data point gets put up here in the mind. Where did I fail? Where did I succeed? What could I do better? And having the humility to kind of like reinvestigate the case, your successes and your failures, but also having systems in place to know where you succeeded or what you failed at. What have you found to be very successful in that process of determining where you've succeeded and where you failed? Is there like a system that you have in place, either internally or as part of your clinic system, to kind of track, again, where you failed, where you succeeded with that case, so you can build confidence rep after rep and you do have that feedback loop?
Twofold. Obviously, with Chiro, we do that. We do it both on two levels, both clinically. So at 30 days, a patient is asked a survey that says, Dino, you saw Dr. Steele, you have rotator cuff syndrome or whatever it was. How many times you see him? What % better are you? How satisfied are you with your care? And on a 0 to 10 scale, how likely are you to refer this practitioner to a friend? So two of those questions are pure, like, personality wise. Was that relationship good? Is it a good experience for you? We can get a net promoter score out of that. Interestingly enough, we have, 3,000 clinicians around the world in 16 countries. And when it comes to an NPS, which is a negative 100 to a positive 100, a really good, like a 4 is, I think, like a 62. A typical business customer, a business that has a person present, meaning you actually have to do business with an actual person. A really good business around 30. So our chiropractic network was at 90. So
wow, that's impressive.
So the cool part is patients love what we do because we care. We have that empathy. And I'm very excited for that. I think that's something that just shows the amount of caring and the amount of humility that our profession does have. So I think that's the first piece. But then, when it gets into the clinical side, that's sometimes a tough one to swallow. So we measure all those. And if I'm not getting good results, and I can measure those across my clinic, across my clinicians, and then across our entire network, I can see what I'm not good at. So I can see where, cervicogenic vertigo is usually pretty quick, 3 or 4 visits, 100% better. They're at my door because it responds to manipulation of soft tissue. If I have someone with lateral epicondylosis, they're 50% better. Well, is that good or bad? I don't know. I mean, the patients are happy, but they're only 50% better. And then I go across my network and everybody else is like 90% better. So then we need to kind of look at ourselves, look at our protocols and see what could be changed. And I don't need to change everything, but also having that touch of humility and say, I can get better at this. Go back into the research and figure out what you get better at. Surprisingly enough, from that, we did a research study it was right before COVID. So it must have been maybe 18 or 19. There are 670 condition reports, 670,000 condition reports put out. I think it was a 6-month period. And the number one condition that gets the fastest results with the highest patient satisfaction was BPPV, which is crazy. That's not even a musculoskeletal diagnosis.
Yeah.
But I mean, so it's interesting on what you can learn from data. And we get so many people who are upset or worried about AI taking over healthcare. It's never going to take over healthcare. But with that being said, it's amazing what you can do with data. Then for us as practitioners to synthesize that data and make better decisions.
The BPPV thing's an interesting one because we don't see many chiropractors marketing towards primary care physicians, neurologists, or even physiatrists that they may trickle in through their door. And if the data and outcomes are so great, it's like, why are they on 14 different medications and struggling with this for 5, 6, 7 years when we can help resolve these effectively within 3 to 4 weeks? So
that's the only way we market. So the only thing I do is twice a week, I go into a hospital, twice a month, sorry. I go into a hospital system and we work with 2 medical physician groups. And all we do is talk to them. And we do great mimickers. So, that issue, that it's not sciatica, if they have these symptoms, it could be coming from an intrasciatic nerve from somewhere else. Or cubital tunnel syndrome, or a lot of your peripheral neuropathies are those ones that kind of go through the cracks, and they think they have plantar fasciitis, but it could be something else. So it's kind of fun to educate them and for that light bulb to go on their head that maybe there's another option, and maybe I can give Dr. Steele a chance to see what he can do as a chiropractor.
Doc, so how does one build up soft skills? There's the hard skills, the being great at evaluation, palpation, manipulation, soft tissue work. And there's the soft skills, being just a good doctor, a good manager of the case, saying the right thing, listening to the right piece, or how a patient says what they're describing to you. How does one get better at the soft skills? We're never trained at doing that. We're always trained for the technical stuff, but this conversation has evolved into the soft skills matter. How does one get better at soft skills?
I think there's a big difference between perception and perspective that I think a lot of healthcare providers, I'm not going to single out chiropractors, that we like to live in our own fairyland where, every condition and every person can be treated by us in this case. And fortunately for us, a lot of people do get well, but not all. And we can all live in our own fairylands if our ego is big enough. But the hardest part is to recognize our failures and our mistakes. So I would say you definitely get curious when you make a mistake. And that, my goal is to get people out of pain as fast as possible and prevent them from coming back. And I hope I can do that for everyone, but there's a lot of people who don't. So the first mistake that I'll see is someone who's not confident and they say, "Oh, I've tried everything, go see someone else." Well, in the world of musculoskeletal care and compensations and the layers of issues that people have due to the chronicity of their condition, that just because you get rid of one problem doesn't mean the entire problem goes away. Like if you look at the shoulder, they have a rotator cuff syndrome. Well, 95% of them started off with impingement syndrome and 100% of them start off with scapular dyskinesis. So you're kind of, once you get that strength to come back in the rotator cuff, now are you teaching the strategies to stop impinging that tissue to begin with? And then are you doing the scapular stabilization exercise to prevent the whole thing from, snowballing again? So I would say just because the initial pain doesn't go away or the problem doesn't go away, keep on looking a little bit deeper, but also keeping in mind that a patient came in to see you because they wanted one thing. So make sure you solve that one thing fast and then move on to the next thing. Often I'll hear people like, "Well, I don't really want to get my patients out of pain that fast. I've got bills to pay." And I can appreciate that. We're all running a business here. So I understand that. However, we have to have a clinical hand and a business hand. And that clinical hand always has to be above the business hand. We always have to provide those strategies, tools, advice, treatments that are truly going to benefit someone versus someone that's going to benefit us. So we have to be service oriented in that aspect. However, we don't need to see patients for life for the same condition. Do we need to see people for life? Absolutely, 100%. I hurt myself every weekend doing something dumb, and so do your patients. So, be that place that they can come back and they can have another, have another go with a different condition. I think that's one of, I talked about BPPV a couple minutes ago. How many of you have had a patient that's gotten off your table and you're treating them for back pain and they go ahead and sit up and they have a little bit of dizziness? There's an option here. Option number one is stabilize them. "Okay, Sally. Okay, now how's your back doing?" That's option one. Or option two is, "Okay, Sally, do you get that dizziness a lot? Is it always when you do this? Have you been experienced this getting worse throughout the weeks?" And going and evaluating that next condition. Because people have a lot of problems these days in the movement world. And I think that the more conditions we're able to confidently treat, the better off we're going to be. So yes, the hard skills as far as knowing how to treat it is a big piece, but also knowing how to set up those patients to be, one, an easy place to fail. I mean, if they don't do their exercise, they don't get out of pain quickly, that's okay. Let's try something different. Let's try, switching gears. And then the second piece is making sure that you have a repertoire of things you can treat. Because I know, down in Texas, you guys treat a lot of things, but when I see a patient for back pain, they think I'm a back pain doctor. They have no idea that I work on the feet or the knees or with dizziness. So having skills, and this sounds really old school, but we have rack cards in our office, just little cards that say all the things that we treat, because patients don't know. And why would they know? They think we're chiropractors, we're back doctors. So making sure their patients know what we can treat, what we can't treat, and then making sure that when we do treat it, we treat it confidently and we get pretty good results.
Are there any training courses, seminars, books, that you've come across that can help people kind of build those soft skills? I mean, the one that kind of resonated to me recently was when I watched Annie O'Connor on several webinars, and I've seen her in person discuss, and she puts case presentations. And I see her interactions with patients coming from a place of really big empathy, and then listening, and then no judgments. And then, after a while of seeing some of those videos, it dawns on me, man, I am like not even halfway there. And she's great at it. But if you come across anything that really has kind of built or can build soft skills, especially in young providers and practitioners?
I hate to go outside of the profession because I've read, World of Hurt, and I know where you're going with that. I do think at a certain point, clinically, I stay within the profession, as far as all people I do business with, as far as the information that I get. I will say when it comes to business and when it comes to communication, I do tend to get outside of the profession and to get different perspectives on how to sell, how to understand your accounting and your profit and loss system. I'm not going to get accounting information from another chiropractor and go to an accountant. So when it comes to communication skills, there's different personality types, different educational styles. So I would say there's many different kinds of books to understand your personality. And then as soon as you understand your personality, the hardest thing that I've ever had to do was to recognize, what I'm good at, but probably even more so that not everyone thinks like me. And that's okay. That we need to understand that, like I said, that 90-year-old with stenosis, they have a different educational standpoint, and they don't understand the things that we understand. So I would say going into personality books and figuring out exactly how you communicate and what works best for you, and then understand there's different ways of communication. I know it sounds kind of boring, but it's been eye-opening to me to understand, as far as relationships, as far as patient doctor interactions. I think that'd be pretty powerful. I don't think there's a great chiropractic book when it comes to that, because we need to get out of that realm to understand people a little bit better. I will say this is that the reason people don't come back is because they don't understand why they have to. Because sometimes we understand a condition very well. However, if I told you, Dino, that, listen, Dino, you've got lumbar spine stenosis, I need to see you 3 times a week for 4 weeks. And then I get you out of pain, everybody's pretty happy. But then the next time I see that same person and they have carpal tunnel syndrome, I need to see them 3 times a week for 4 weeks. And then they have a cervicogenic headache and I need to see them 3 times a week for 4 weeks. That doesn't make sense. So I think that the more transparent we are with our treatment plans helps convey that message a little bit better. As far as during my report of findings, it's, this is the tissue of injury. You have a muscle strain. Well, a muscle strain should get better in 3 days, maybe 7 days, but really this should be a 1 week kind of diagnosis. And being very transparent with that. If someone has, rotator cuff tendinopathy, is there anything that you can do within a week to strengthen that muscle? No, not to a certain, extent. It's going to take 4 weeks. So having that little candid conversation with your patient, like, listen, here's your diagnosis. Here's what I can do. I can loosen things up. I can get things moving. I can give you the right set of exercises. Here's what you can do. You can do the exercises, but it's still going to take that tissue that amount to heal. So I think one of the things that are lost in that communication is that prognosis, because that prognosis depends on the tissue that's injured, not whatever's easiest for your practice manager to book them for their trial of care. We have to make sure that our messaging is consistent with their diagnosis and not just our policies within our business.
Yeah, and when I have patients that come on in, I try, at least me personally, in the first couple of minutes, is try to get an idea of how they say things, their mannerisms, how they carry themselves, how they walk back here in the lobby. Are they looking at their phone intently? Are they surveying the situation? Because I want to know your learning style. If you're an audio person, I will talk to you during your report of findings. If you're a visual person, I need graphs, charts. I need shoulder models, hip models. I need to draw things out. If you're a kinesthetic learner, I ain't going to talk to you. I'm not going to draw things for you. I'm going to put your body in certain positions so you can feel whether it's an activation of our muscle group or that's a provocation position, for your impingement test. Got it. Right? This is provocative. This is provocative. Let's limit those positions temporarily. So I think the thing that's kind of helped me over the years is, with my failures is, did I not get the patient's learning style? And did I ask the right questions? What are you here for? And what are your goals and expectations? What's your time frame? And then the last one, what are the obstacles that you would have to getting towards your goals? time, money, energy. I don't believe in chiropractic, whatever that may be. Yeah, and then again, okay, I got that now. Let's reverse engineer the process. That's kind of helped me over the years.
So before you get into the next part, have you ever told someone, when you meet a hard rejection that, listen, I don't think I'm going to be able to treat you?
Yes, I have. And it's only been in the last, and what are we, Brandon, 13 now, 14, 15 years into practice now?
Well, I'm
2009.
27, and the math is
Yeah,
kind of
14,
fuzzy.
15, I think.
Yeah.
Yeah.
Uh,
I
but
only got to doing that, and it took me about 10 years to feel comfortable enough when a patient puts up a really hard pass to just say, I just don't think we're going to help you on out. Let me get you to the right spot. And I don't even try a trial of care. If they're already putting up that wall, then, the rest is not going to be pretty. And then that's also when they start to say negative things, not just negative things about you, your practice style, et cetera, because you missed the fact that that was not a speed bump. That was the brick wall. It was already there.
yeah, I agree, because those are people that probably aren't going to get better. They're just energy vampires, and it's about recognizing that and finding another place that can better deal with them.
Yeah. Yeah. And that's okay. We all want the same thing. I want you to get better. You want to get better, but it's not going to be here. That's okay. Let's get you there. You know? So, and I actually flip it into a positive. At the end of the day, I'm like, good, right? The patient is out of my practice. Good. The patient is getting exactly where they want. Good. We didn't waste your time, your money, or your energy. Like,
Sure.
and it's perfect, right? Let me ask a question. So, I think you're a really good, astute clinician, and I've known you for a couple of years. But there are things that you see because you're able to not only be a great astute clinician, leverage the data of chiro. Let me rewind though. There is probably a handful of people that are going to be watching this podcast that don't know what chiro is. Can you give me a little intro for the masses, what it is, what it does, why you're tracking this data, what's the long game? Can you give me a little bit of that? Then I'll rewind and ask the question I'm going to ask.
Yeah, I mean, Chirop's a software program that Tim and I just created for our own office. So we just wanted a way to standardize the care that we were providing to our patients. And it snowballed into what it is now. But really what it is, a knowledge transfer system. So we have a team of 2 chiropractors that work part-time that go through the research and develop what are the new evaluations, treatment strategies, patient education pieces, social media pieces, what's in the research, what's in the literature right now that chiropractors would care about. And so we have 180 different diagnoses, from tarsal tunnel syndrome to cervical disc lesion. And we go through all the research, and we have a board of directors that goes through and says, okay, what's the evaluation? What's the treatment? What are the symptoms, the signs, the radiology considerations? What's the the management tools for each one of those conditions? And not what is the chiropractic standard of care, not what is the medical standard of care, just what's the standard of care? What does it involve? Does it involve manipulation, manual therapy, exercise, and then which manual therapy, manipulation, exercises? So it provides a standard of care by which we can assess and treat. And the second part of that is to take that same information and now deliver that to the patient. So your patient can be compliant with their care. So does your patient understand what carpal tunnel syndrome is? Do they have a printout or an email or a text or on their app, however they want to learn? You can deliver their exercise and their education via that platform. So it's a quick way to take everything you know about a condition and give it to them. And then we, of course, gather stats on that to say, hey, I saw Dino for 8 times and he's back to 100%. And then we send them a survey to get those results. The cool part about that, though, is that now we gather stats on the chiropractors, and now we can take the evidence-based information, which is what we have, and now we can get the evidence-informed information from that chiropractor, because we can survey the 3,000 chiropractors around the world and say, who's doing the best job? And we have the stats behind it, and then they turn around and teach us a webinar on what they do differently. And it still allows the chiropractor to do whatever they were going to do. However, now you have evidence-based, evidence-informed, and you can make a better decision on maybe those conditions that aren't going so well in your clinic, and provide you some more ideas for those type of cases. The projection of the company is much different. This month, we developed an EHR. The EHR has been running in our clinic for a year. It's been fun.
I can't imagine the hurdles to get something like that implemented, not just in your office, but hopefully
I,
growth of that. I can't imagine the hurdles you had to jump through there.
I can say with 100% conviction, Tim and I had no desire to create an EHR, a zero desire. Chirop was doing just fine. However, we created Chirop for chiropractors to solve the greatest problems they have, and we continue to add functionality like MD initial reports and Google reviews. We've added all those things, and we just were into it. People said just develop an EHR, so we took 2 years and did it. So it's up and running. We have our first beta group going live next month, and it's exciting. It's going to do some things for the profession that no one else has thought of. So yeah, thanks for giving me that idea or that plug there. But yeah, it's a fun company to work with, and most importantly, it's designed to kind of adapt to where the profession needs to go in the future.
Having said this, now you have the power of looking at data, leveraging data, clinical experience, clinical excellence, clinical mastery. What are 2 to 3 conditions? We're going to go upper extremity, lower extremity, and spine. And the upper extremity that providers misdiagnose, mistreat, mismanage. What do you see our common faults are? This is the clinical mastery piece.
Let's see. Upper extremity was first. I would say the number one thing that I'll see is unresolved carpal tunnel syndrome, or not responding carpal tunnel syndrome. And I think the one thing that I've learned over the years, not that I've learned, but that I've recognized over the years, is that there's a palmar branch of the median nerve. So if someone has numbness and tingling in their palm, then that's not carpal tunnel syndrome. Carpal tunnel syndrome could still be there. However, if you get numbness and tingling in your palm, then that compression has to be upstream. It could be the peroneal arteries, it could be a cervical radiculopathy. However, it's not just carpal tunnel syndrome. And everyone learned in school the double crush injuries, and carpal tunnel syndrome is no different than those. So any carpal tunnel could have other parts, but usually pure carpal tunnel is just the fingers, the first 3.5, depending on how you're wired, kind of numbness or tingling. So I'll get people that will have these problems, get the surgery, and they still have the problem because that wasn't the only problem. So I would say, utilizing some upper extremity neurodynamics, and then also considering what's making it worse. With your peroneal arteries, the people, I can't see my desk here, but people that constantly keep their forearms on their desk, kind of rule in the diagnosis. But we're really good. Chiropractors are really good at ruling in diagnoses. But are you ruling things out? Can you do a maximal foraminal compression test and reproduce arm pain? Probably not just carpal tunnel syndrome, So, those are the kind of things that I care about, is not necessarily what tests are positive, but making sure the tests that are negative are negative. And then I think finally listening to the patient that has a peripheral neuropathy, that's the mostly nighttime pain, nocturnal pain, just the location of the pain, the type of the pain, and just to make sure it's not other places, because as a chiro, I can kind of get laser focused on, well, this is carpal tunnel syndrome because everyone else is treating it. Let me see what I can do. And I think that's where sometimes we get kind of stuck in looking at the same region of the body that everyone else was.
Do you have a second one in the upper extremity besides the palmar branch of the median nerve?
Do I have a second what?
Yeah, a second one where you start to say chiropractors misdiagnose, mismanage, mistreat.
Oh, the upper extremity?
Yeah. That's a good one because double crush is definitely a thing. And knowing that there's an anatomic variant that's slightly different is a good thing. And, me personally, I still see too much surgery recommended for carpal tunnel out there and patients that don't get the benefit. And then you see a frustrated patient that was put through a surgical situation to which, if the diagnosis is right, they should theoretically have a benefit, and they've had years and years and years of tingling, and they're just not happy. They're not in a good place. Or worse, They've had, pain medication, addiction, chronic pain, anxiety, depression over it. You started a bad cascade.
Yeah. So, I think the number 2 upper extremity. So I do give a class a lot for the rotator cuff. So I try to always give different ideas because I'm so used to giving those. So I think the number 2 is going to be thoracic syndrome. That so many times people look at an ulnar nerve neuropathy and they're treating the neck. And that's there's nothing wrong with that. However, taking a look at, Wright's test and Adson's test, also has to see if there's a peripheral aspect to that nerve compression. We don't do Roos test anymore. That's with that 3-minute, test. So the Syrian, but Syrian does a pretty good job of ruling that out. But I would say that's another one. as far as thoracic outlet syndrome, because they will get numbness and tingling in the fourth and fifth digit. And then unfortunately in today's world, a lot of our patients are sitting kind of with that, that forward head posture at school, at work, whatever it may be. So I see a lot more of that these days. And one treatment tool, like it's not a secret, but I love the corner pec stretch, which sounds kind of weird, but you put your elbows in the wall. And this is a case study. This is not a reproduced study, so it is what it is. But my favorite exercise is doing the corner pec stretch. But once they pin their elbows to the wall, then let them drop down a little bit. And when you drop down a little bit, you actually preferentially get that pec minor and open up that space where that ulnar nerve is. So that plus the ulnar nerve floss, man, we're rocking and rolling, getting people out of pain when no one else was.
How do you use the thoracic outlet orthopedic testing cluster? I use it, and rightfully, wrongfully so, as an audit, like 10 seconds, reproduce pain with an AdSense or a modified AdSense. I'll retest it a week or two later. It went to 30. Now I'm tracking that there's 20 seconds of improvement, and that has led to increased ability to grip, hold, squeeze things, etc. I use it more of as a clinical audit. I have used it in the past where to direct my soft tissue treatments. How do you use those orthopedic tests for that diagnosis?
Yeah, so I don't do it every visit. I'll do it, the first exam and the re-exam. Fortunately enough, with those tests, we're supposed to check the radial nerve, but realistically, to get any kind of vascular symptom, whether it's an artery or vein, to see a change in pulse is not very common. So that's a good part. We don't want those vascular sources of TOS. So it's usually neurogenic. However, it's going to be normally that numbness and tingling. So nerve compression has a very characteristic response that, unfortunately, just what you said is grip strength. So if you start to lose strength, especially with opposition, we've got some long-standing compression. We've got some significant compression on a nerve to lose strength in that muscle system. But then once it starts to loosen up a little bit, then that's when you get the tingling. When you get a little bit less, that's when you get numbness. That when you get a little bit less, that's when you get things back to normal. So you can kind of judge things based on the symptoms, and then also I do prefer using more directional therapy type things. We're looking for centralization of symptoms throughout those different visits. Those are my main, audits that I'll use.
Okay, let's flip it. We talked about 2 for the upper. Let's go 2 for the lower that are commonly mistreated, misdiagnosed, mismanaged.
Lower, the absolute number one misdiagnosed case that I constantly see is Seaver's disease. It drives me absolutely insane when I have a 10-year-old in my office and they have chronic plantar fasciitis. And I'm like, holy Jesus. So, knowing what we know is that the weakest tissue gives way. So it doesn't matter who you are, what age you are, what sport you're playing. It's just whatever tissue is the weakest. And what we know about Steele is that calcaneal pappas, I think it starts around 7, 8, maybe 9, and it doesn't close till they're like 16 or driving or something like that. So that's the weakest part. The Pappas is the weakest part, not the Achilles tendon. In fact, I just had a patient come in. He's in 2nd grade, maybe 3rd grade, and was playing baseball, hit the bag, and his knee went back into flexion, and he tore his ACL. And I was like, tore his ACL as a 9-year-old, 10-year-old? That can happen. I'm not saying that can't happen, but what's the weakest tissue in a 10-year-old? It's not tendon, it's bone. And then after all swelling went down, they realized the tendon pulled away from the bone, so you tear your ACL in that age group, you're out. They do the surgery, you're out months. You're out 9 months, 12 months.
9 months to a year.
Yeah, you get the bone, they take a drywall screw it down your back in 2 months. Probably not a drywall screw. However, it's getting the right diagnosis. So I think that's probably the hardest part, because what I found in practice is there's 3 terrible P's. The first terrible P to treat is going to be someone who is pregnant. Pregnant patients are just weird. They're just not normal. They have double the blood volume. Their body habitus is changing. Their center of gravity is changing. They're odd. The next is going to be post-surgical, because they're not normal. Their orthopedic testing are no longer valid because their tissues are different. And then the worst P that you will ever treat in your entire life is a parent. So when you're treating their kid, they want to know, does little Johnny have a chance of playing in his baseball game, even though he has a fractured, elbow? And it's like, come on, people. So I would say Seaver is my number one diagnosis. And unfortunately, in those younger populations, there's nothing you're doing to them. In fact, there's nothing you should be doing to them, especially in the very beginning. So unfortunately, it's having a very honest and frank conversation with that parent saying, you're shut down for 4 weeks. And then we're going to retest. And then what's going to happen? They're going to go get a second opinion because they don't like that answer. So having confidence will give you, at least some ability in there. Number 2, any questions? I mean, is that?
No, that makes sense. Yeah, volume control, and especially in this day and age of youth sports where it's year-round sports, do the same thing over and over and over and over again. Mom and dad have invested tens, maybe up to $20,000 in the kid playing sports. You have to tell them what's making them a good athlete, practice and repetitions, also breaking them down. And you need load management, load modification. And sometimes they quite honestly don't want to hear it. So the management piece and the important piece to that is EUF's disease. Okay, this is predicated on getting you optimal load. And if we go back to this or have you fight through this, you'll never get that. And then with all those bad reps that your child is getting, either they're training a compensatory pattern, they're not able to optimize their athletic potential, which is what nobody wants. So it's a tough thing to manage because you have to have that hard conversation. They have to be willing to listen.
Yeah, absolutely. In high school, my coach always said, practice doesn't make perfect, practice makes permanent. And there's a lot of truth to that. Second condition is going to be for an older population than 10 would be glute tendinopathy. If I have another patient who comes in my office because they have a hip pointer or they have, bursitis in their hip, I'd like to beat them with their own leg. It's such an overused term. And unfortunately, when you lay in your hip and you have a tissue that's trying to heal, it hurts. So I don't know what the statistics are. I know that when I work with patients, I'm much more in tune with, do I have an itis? Do I have an osis? Or do I have something else? And glute tendinopathy is extremely popular. The unfortunate part about that diagnosis is that you need to strengthen tissue. And I tell patients, listen, Dino, if you wanted big bulging biceps and strong biceps, and I gave you bicep curls today, how long would it be before you had big bulging biceps? And it's going to take weeks. It's going to take months. So patients will understand that if you can put it in their terms. But the same goes for the glutes. The glutes are designed for explosive maneuvers, running, jumping, that kind of stuff. We just don't use those as we grow up, unfortunately. So those do start to get weak and atrophied if we sit on them all day long. And unfortunately, when that happens, we have weak glutes and they start to degenerate at that point. So that'd be the number one diagnosis that I probably treat in the lower extremity.
All right, let's flip it. Last 2, spine. Give me 2 for the spine. Misdiagnosed, mistreated, mismanaged.
Well, we just did our podcast on this one because of pure frustration I had a conversation with another provider, not a chiropractor, about ribs being out. And I was like, where'd they go?
Where'd they go?
Yeah.
Is this patient standing, walking? Yes. Are they breathing? Yes. How could it be out?
So there's tons of rib problems, though. Like we can agree that the costovertebral issues are common. So there's nothing wrong with that. But I will say that, and that happens, I will say that the vast majority of people that I'll see that's not acute, meaning it's been there for a while, those are people that are rubbing on a door frame or having their spouse, massage underneath their shoulder blade. It's dorsal scapular neuropathy. And it drives me insane because when the chiropractor adjusts it, it feels better, but then it comes back. I'm like, well, because it didn't go anywhere. The problem isn't there. So I would say that, doing a test, just pure neck flexion, doing a retraction, which will actually pull the spinal cord, something like a maximal foraminal compression test. If you turn your head and go back into extension and it makes your shoulder blade pain worse, it's probably not a rib. Yep. So I think that, doing the right test to rule things out, and then also the quality of symptoms. If you get achiness, it's dull, it's constant, it really doesn't change based on position. Chances are it's not, a musculoskeletal complaint. One interesting thing with ribs is that ribs get worse when you lay down because of the compression. Most of your dorsal scapular neuropathy actually gets better when you lay down, as long as your head's not held in extension. So kind of massaging someone around and kind of figuring out, what makes the symptoms change and making sure that makes sense and it's not something else.
Yeah, I would agree. Scapular pain, I used to look at it years and years and years and years ago as either being rib cage, maybe thoracic spine, potentially you have a posterior shoulder problem. And the more I got it and the more failure that I had, And then obviously going through the McKenzie training, I went through all of it. I start to find out cervical referred pain into the scapula is a bigger deal than I once led on to believe. And you'll hear it in their history. People that like push onto a door frame, use a lacrosse ball or a tennis ball, feels good, problem comes back. And they keep doing it and doing it and doing it. Now you've got two problems. You never fix the first, and then you've got bruising soreness over your scapula that is self-inflicted. So yeah, I took it for granted too. Like you said, that scapular and posterior rib cage pain can be cervical referral or cervical derangement if you're a McKenzie guy. What's the second one, Doc?
Compression fractures. I would say that's one that I don't want a license stealer. However, that's one that you don't want to go pounding on a tissue that's been broke. So I would say recognizing of a certain population, in a certain history as far as trauma, but it doesn't have to be trauma. And that's where I think most people get confused, is that there was no fall in the butt. However, I have a 7-year-old with this constant pain. I think there's I hear constant pain. That's when my ears perk up. Musculoskeletal pain is made worse with certain activities, certain postures, movements, time of day, whatever. When it's constant, it tells me something chemical is wrong or something significantly structurally is wrong. So one, rule out chemical versus mechanical. But in this case, the weird thing about osteoporotic compression fractures is a supine sign. So when you lay down, it actually gets much, much worse. So that's a thing. Now, I will say that there's a difference in confidence level and treatment of the provider. So as a chiropractor, can you treat a compression fracture? You can manage that condition just fine. Now there's certain situations where you can't. If they're getting neurologic complications, you need to send them somewhere else. However, if they're not getting anything neurologic, doing gentle mobilization of the tissues above and below, working out the muscles, doing pain control, bracing, those are all things you can manage in your office. If there are certain significant other things, then we need to worry about that. We can send them to pain management. But pain management, doing concrete in the joint, while it will help for certain situations, it does set that person up for problems at the level above, because anytime we have a fusion or if we have a vertebroplasty, we'll get adjacent level disease, because unfortunately that's going to now put that stress on level above. So if someone is able to manage that discomfort, and I'm able to manage it with a brace and some soft tissue, some flexion distraction, within 4 weeks, they're going to be feeling better. That's one of those conditions that I think that it takes a little bit of confidence to look the patient in the eye, like, hey, this is going to hurt for a couple of weeks, but we'll keep it loose. We'll get it feeling better. And if we start to get neurologic complaints, I can refer you on, but otherwise we're going to manage that here in our office.
Gotcha. Doc, let me ask you about one case or two cases that you've kind of put the whole package together in your clinical, in the 14, 15 years you've been in practice. So can you give us an example of a case where nailed the assessment, diagnosis, management, and you effectively communicated? Kind of give me a success story from start to finish of the case where everything kind of worked out for you.
Well, that's every case, Dino.
Yeah, that's right. 60% of the time it works all the time.
Yeah, I mean, I guess I don't have a specific example because I maybe I'm living in my own fairyland. I should take my own advice. But, I would say that the vast majority of the cases, go that way. We're very fortunate. We work with two pain management, two medical physician groups. So we get a lot of cases that are acute. And I think that helps us out a lot because bodies heal. It's our job to kind of keep things loose and teach the patient how to keep things loose when they're out of our office so tissue's allowed to heal. I would say that a case that stuck out in my brain, I'll go into the ankle actually. So I do treat a lot of athletes, and I will say that sometimes with treating athletes, it's difficult to get them out of their sport and to allow them to heal. And so one case that I did have that I was pretty proud of was an ASIS avulsion, and it was deemed non-surgical before I even saw the female for it. And, it's one of those things that you poke on and it hurts, and you do the imaging and you see it. And then the biggest concern is, what do you do with this patient? And so she was a soccer player, and we'll see ASIS. We'll see a lot of issues with our runners. And I say that the biggest thing with that is that once she was done with her care, meaning which was mostly rest and do some gentle tissue, I told her, I was like, listen, you've been having this hip flexor pain for 2 years now. And now that you're completely out of pain, we have one of two options. One, I can just send you back into playing soccer. Or two, we can actually kind of attack the cause. And her parents chose to attack the cause. And what we found with a lot of like single leg lunging, lower extremity Y balance evaluations, this female, while she was, let's call her 14, maybe 15, was a very strong. I mean, if you looked at her, she's lean and built, a high level soccer player. Her butt muscles were unfortunately not very well, conducive to cutting and moving. So that was one thing that we were able to attack with a functional mindset of, listen, whenever your knee goes into flexion, we're seeing diagonal vagosity. We can do things to strengthen the foot, which we did, and then also things to strengthen the hip, which we did. And now 3 years later, we haven't had any more issues. So I would say I'm proud of that because she came with one problem and we were able to correct, I think, the problem that she was actually having. And that's one of the hardest things about orthopedic diagnosis is that orthopedic diagnosis tells you what injury they had. That's what's injured. That doesn't mean that's what you have to treat. And you need to be able to recognize it and say, hey, you injured this tissue, but just allowing them to heal from it or just surgically repairing it doesn't fix anything. Getting someone with a knee replacement or a hip replacement, it doesn't fix the cause. They still need to go through that rehab. So I think that's one of the hardest things that has been in my mind is that, yes, I can get tissue to calm down. We're all pretty good at that. But having the understanding to build tissue back up is probably one of the hardest things to do in my mind. And having a really solid rehab program to say, you don't need to do these 17 exercises that's on a PDF from a different office. You need to do these three. Do these three, and I'll see you again in a week, and we'll see how you're doing. Do these four, and then we'll see you again in 2 weeks. And giving patients the freedom to kind of help themselves along with the resources that you give them. So I'd say that's probably that was probably my favorite, just because when you get a signed picture of that player at the end of their college career, while I had nothing to do, zero to do with her college, her ability to play soccer, I do feel a little bit of responsibility and I'm proud that I was able to play a small part in that person's life.
Yeah, you help her maximize whatever athletic potential she potentially could have, which is fun and rewarding. And I like it. The soft skills, the sales piece was you went to the parent, hey, this recurring hip flexor issue, oh, by the way, it has a cause, and the cause is not what you're seeing on an x-ray. And we can prop her up to get her to play soccer, or there's a long game. And if we play the long game, the outcome is potentially significantly better. And then all these little problems hopefully will go away, come away in the wash. So that's kind of a good tactical piece is what's the long game here? And if long games are going to continue to play soccer, then propping her up, you're going to have to keep doing it over and over and over again. If we fix it now, hopefully it's significantly better for years and years and years to come.
Yeah.
Last little tidbit, we're going to close this down. What are 3 big takeaways? What would you want our audience to know about this topic of clinical, again, taking information, evidence-informed, evidence-based practice, and merging it with patient communication? What are some takeaways that you want people to know about?
I think the first one is that I always get this doom and gloom feeling when I leave a chiropractic seminar, and it's so weird because I feel like our profession is on this accelerated path to growth, and I think that there's not a better solution to musculoskeletal care than finding a provider that cares. And when it comes to that, chiropractors fill that void, as far as that non-surgical, non-pharmacological void. And it's also recognizing that some people do need surgery. Some people need medication. Some people need other things. That's okay. That's fine. And understanding our place. And it doesn't mean we have a limited place or a place inferior to other providers, but you're not great at everything, and that's okay. In fact, like diet. I think diet is one of the most important things you can do for your health and has significant implications on pain. But I'd rather change your religion than change your diet. Like I'm not good at that. Like I recognize the importance, but yet I don't treat that. That doesn't mean that I can't give that advice to a patient. I just need to find a functional medicine doctor, someone in my area to talk to them about the diet. So I think that, getting out of our box as a profession to say, hey, I'm really good at X, Y, and Z, but for this specific part of the treatment, maybe I'm not the best. I can get them in the right place. I would say the other takeaway is scalability. And I think that our profession is an interesting one, that we don't have a common language. We don't have common diagnosis. We definitely don't have common treatment plans. We don't have common things that we do to our patients. So if we had that, that's how you scale a product. Meaning, are you in Austin, Texas?
I'm in Austin. Yeah.
And you have young kids, how old's your daughter now?
She's going to be 10 here in about a week.
So when she was getting ear infections, which all kids get, it is what it is. And I'm not saying this is right or wrong or indifferent. I've got little kids. However, if you took her to the pediatrician and she had an ear infection, she would get amoxicillin, or she'd be offered amoxicillin. Let's say that. Guess what happens in St. Louis? I take Jameson to the pediatrician. Guess what he gets? Amoxicillin. Guess what you'd get in New Jersey? Guess what you get in Alaska? The same thing. It's called a standard of care. Yet if you have back pain and you see 10 chiropractors, you're going to get 10 different diagnoses and 37 different treatments. That's a problem. And I don't have the solution for this. So I'm not saying anything about that. However, I'm saying that if we want to scale a profession, if you're going to be in an organization that can scale as far as multiple locations, multiple providers, there's standardization. It is what it is. That's okay. That's just fine. It still allows you the ability to make good clinical decisions on a patient by patient basis, but we need to be able to scale our profession. And I think it starts with one thing, which is the third thing. It's our notes. That it is unbelievable what is in our notes as a profession. I should say that. It's unbelievable what's not in our notes, meaning justification behind the charges. And you know what? Here's the deal. We can stick our head in the sand and we can say, oh, not me. Oh, trust me, it's me. I've done audits on my notes and I'm not good enough. So it's finding ways as a profession that we can not only do the things that we say we're going to do, we can document it. Because if we can do those things, we can be great at what we do and we can document it and we can show the results. That's called data. And like it or not, that's how we're going to get paid in the future. And I don't like it, but I think that I'd rather own the data than have someone else, massage that data around for me. So I think that those are the biggest takeaways that I see in the profession, is that we're growing and that we're in charge of our future. And I think that it's a really cool place to be, because right now we're having other companies and other organizations buy up companies within chiropractic, which I don't think is a good thing for everyone. So I think that if we could start to work together instead of shooting, within the inside, we're going to find great ways to come together and to accelerate the growth of the profession and to impact more patient lives in a positive way.
Yeah, I'm looking forward to the next 10 to 15 years, for the simple fact that we have as a profession good evidence-based chiropractors, physical therapists, even our colleagues, cost-efficient, effective options for most neuromuscular care. And if you're efficient, you're effective, and you can leverage data to show that, the end game is that you will have a place in the future of medicine. You'll have a seat at the table. So rather than run from it, put our head in the sand, embracing it, and then moving towards, stepping aggressively towards the future, right? And then what does that future look like? Well, better autonomy, better integration into healthcare systems, possibly, you're the first provider that the insurance company will approve to see for X, Y, and Z, so they don't have to go to the specialist. $500 for the evaluation, and what'd you get? You got a prescription for meloxicam, and how'd you do? A month later, you still have it. And then you go back, and then they finally refer you out to PT, when it could have been done cheaper, quicker, and more effective if that was, you were the screening tool. You were the portal of entry. So yeah, I'm excited because hopefully over time and leveraging that data, we are in that situation. Doc, I want to say thank you for your time. Real quick, where can people reach you? How can people reach you if they have questions, whether it's about classes, courses that you're teaching, whether it's about Chiro Up, or whether it's, give me your best dad joke. Where can people reach you?
So my cell phone is not. My
Tim's
email.
Tim's cell phone is.
Yeah, there you go. Is Brandon, BRANDON at chiroup.com, CHIROUP.com. But even on our website, on the homepage, there's a tab on there, resources. It has our blog, it has our podcasts, It has our webinars, all clinical in nature. All the things that everyone just heard is all on there. We give it away. And it also has our speaking schedule. You can see where we are. Tim and I both speak for NCMIC. We both speak for the Diplomate Orthopedics program. So we're out and about all the time. And I'd love to hear everyone's thoughts on this podcast and kind of where we're going as a profession.
Doc, thank you so much for your time. We need to catch up next time in St. Louis or if I see you at a seminar. Thanks again.
All right. Thanks, Dino.
All right.